Hello, this is Dr. Amy Boutwell. I am the co-principal investigator of the Agency for Healthcare Research and Quality's Reducing Medicaid Readmissions project. I'm pleased to welcome you to the 6th webinar in our 6-part webinar series to support the dissemination of the Hospital Guide to Reducing Medicaid Readmissions, Designing and Delivering Whole Person Transitional Care. Today's webinar is focused on delivering enhanced services for high-risk patients. The agenda for the webinar is to describe strategies to enhance services for high-risk patients, to give examples of how transitional care services and high utilizer programs effectively meet whole person needs, to describe the usefulness of an emerging tool in this field, the ED Care Plan, and to identify ways to reduce readmissions by engaging the ED, the emergency department, in your readmission reduction work. The objectives for this webinar are for users of the guide to understand enhanced services as services that go beyond standard care to provide services and support to high-risk patients in the post-hospital time period. To encourage users of the guide to adapt transitional care models to better address whole person needs, to help users of the guide develop new services to improve care for frequently hospitalized patients, to encourage users of the guide to use care plans to improve care over time and across settings, especially for frequently hospitalized and other high-risk patients, and finally, to encourage users of the guide to engage the emergency department in their efforts to reduce readmissions. By way of orientation, this is the Hospital Guide to Reducing Medicaid Readmissions, and we are talking today about Chapter 6, Enhancing Services for High-Risk Patients. Associated with this content is Tool 13, the Emergency Department Care Plan Example Tool. To remind listeners, the Hospital Guide to Reducing Medicaid Readmissions is based on the ASPIRE framework. The ASPIRE framework encourages readmission reduction teams to reduce Medicaid readmissions by working through a set of steps, a work to understand and develop a data-informed portfolio of strategies that can reduce readmissions, specifically Medicaid readmissions, and to deploy action in improving care and transitional care in 3 different domains: improving standard hospital-based transitional care for all patients, reaching out to collaborate with cross-continuum providers, and today's topic, enhancing services for patients at high risk of readmission when the former strategies will not be sufficiently robust or comprehensive in order to meet their post-hospital needs. In our field work in describing and understanding transitional care models and the adaptations that may need to be made in order to better serve the transitional care needs of the adult Medicaid population, we had the opportunity to interview several transitional care workers of a variety of sorts and disciplines from the field. And this is what a transitional care worker from North Philadelphia told us. Quote, "I think that there's always going to be a group of folks that's always going to need somebody to help them. That's never going to change." And so when we think about understanding and addressing the whole person transitional care needs of our high-risk patients, whether Medicaid or otherwise, we think about what additional services and supports might need to be in place in order to mitigate the risk of readmission, in order to more effectively and comprehensively support the person once they leave the hospital so that they don't need to come back to the hospital soon after discharge. When we refer to enhanced services here in Section 6 of the guide, we're really talking about the additional services and supports in the time period, usually up to 30 days following a hospitalization. These are services that would not be provided to all patients as part of routine care. They would be offered to subgroups of patients identified in your data or otherwise as high risk of readmission. These are services that are delivered prior to and following discharge, often for a 30-day time period. They can be thought of as deployed at provider expense so as to reduce readmissions. And we add this here to really differentiate this from linking to the services that exist in the community or improving standard care as part of standard operating procedures. So enhanced services are really those additional services that have classically not been part of standard of care and would usually represent some incremental expense to provide, which is of course why teams would want to target and deploy these services and would want to deploy the interventions in ways that optimize the expected results. Enhanced services might be delivered by hospital staff or by contracted staff from other entities. So hospitals often have the choice to make when considering delivering transitional care services. Should we staff up a team to address these patients' needs directly ourselves? Are there providers or agencies or partners in the community that we contract with in order to more effectively deliver those services in the post-acute or community-based setting? So we've referenced high-risk target populations as the target population that would be candidates to receive enhanced transitional care services. And remembering back to the first webinar and the second webinar and the early parts of the guide when we were encouraging you to identify the various high-risk patient groups at your hospital, remember that there may be several target populations at high risk of readmission identified through your data analysis. Consider the following hospital we worked with that identified 4 significant target populations at high risk of readmission: adults with sickle cell disease, adults residing in group homes or other residential settings, patients discharged to short-term skilled nursing facilities, and adults with a personal history of repeated hospitalizations over the past year. These are 4 data-informed, distinct, high risk of readmission patient populations. And even from the description of these 4 groups of patients, one could appreciate that one standard transitional care model is not likely to meet the needs and address the root causes of readmissions for all 4 of these patient populations. So we really encourage that as you design your multifaceted portfolio of efforts, you design enhanced services to meet the needs of each of the target populations that you have identified. So we'll cover now transitional care for high-risk patients. And transitional care is, again, that word transitional, as many of you have become to be familiar with, is really meant to encompass a set of services that are provided in the days to weeks following a hospitalization in a rather time-bounded and time-limited way. The focus of the transitional care services would be to reduce 30-day readmissions. This is a quote from one of the teams we worked with in the field who was describing the transitional care services provided by their navigators. She said, "Our navigators are flexible, proactive, and persistent. They address all needs. Each of them has incredible interpersonal skills." And as we've considered the adaptations to the transitional care models that have been described in the literature, we really feel that this quote well encompasses the type of whole person, proactive, creative, and engaging transitional care provider that we observe is so frequently sought after in the field and so frequently effective with patients. So a few whole person adaptations to transitional care would be the following types of adaptations. To provide active health services navigation of the healthcare system, of the social services sector, navigation of sequencing and executing personal care tasks as well. Hand-holding, actually helping people do something, filling out forms, even driving people or accompanying people to visits, appointments, agencies, sitting with them and encouraging them. Arranging for services, providing patients with the support, maybe some short-term resources, maybe some financial resources to overcome barriers to following through on self-care, such as co-pays, transportation, personal caregiving support needed in the days to weeks following a hospitalization. Other whole person adaptations to transitional care is to adopt a harm reduction approach to working with patients who have a variety of pressing priorities and who are at a variety of different stages of change. And we see that teams that are particularly successful with patients with a clinical, behavioral, and social needs always incorporate a harm reduction approach into their work. They meet the patient, quote, where they are, and really appreciate that they are guests and asking for permission to join the patient on their journey, and that it is important to address the patient's pressing priorities first in order to establish a successful engagement and to really help the person, again, on their journey to stability and recovery. And most of all, we hear transitional care staff of a variety of sorts emphasize how important and primary the relationship is, that this is about human connection, that again, this is about listening and accompanying and hand-holding and helping and supporting. And we propose that all of these types of adaptations are fruitful, whole person-centered, human-centered approaches to improving transitional care models to better meet the needs of the adult Medicaid population. In particular, over the past several years, there has been an increasing use of social workers as transitional care workers in a variety of transitional care roles. And we wanted to bring to your attention one of the more standardized models of social work-based transitional care called the Bridge model, developed at Rush University Medical Center. In brief, the social work-based model of transitional care is developed to engage with patients who have clinical, behavioral, and social needs. The social worker assesses for transitional care needs. The social worker would expect that these needs would change over time. And you employ their existing skill set in motivational interviewing to engage the patient, identify priorities, and encourage the self-care and follow-up that would be beneficial for the individual. Of course, the social worker is skilled in identifying services that are already in place for an individual in both the clinical and social service sector, assess eligibility for additional services to meet unmet needs. They would be skilled in discussing finances in the context of meeting personal care needs and balancing priorities. They, of course, have the ability to link individuals directly to services and to provide brief short-term therapeutic support, especially relevant to patients with behavioral health needs. And finally, social work transitional care workers would be able to coordinate both with clinical and social service providers. We share this example from the guide about social work-based transitional care as developed and deployed at Rush University Medical Center. I won't read the full narrative example to you, but I wanted to highlight the essential services that the social worker provides in the transitional care model of the Bridge program. So here in the middle of the slide, you can see that the social worker would engage with the high-risk patient within 2 days of discharge telephonically. First, the social worker focuses on developing rapport with the patient or a caregiver. And in more than 80% of cases, the social worker identifies problems to be addressed, with about 3/4 of these problems not becoming apparent until after discharge. The 3 most common problems that the social workers at Rush reported were patients' difficulty coping with change, caregiver stress, and problems managing medical care, including medications. So as you can see, from taking a whole person approach, the most common issues are in interpersonal coping, right? Interfamilial challenges with caregiver stress, as well as classically expected clinical problems with managing self-care or medications. Other common issues uncovered by the Bridge social workers included trouble obtaining community services, communication breakdowns between providers, trouble managing a new treatment or diagnosis, and difficulty understanding the discharge plan. In May of 2016, I was privileged to conduct and publish a claims-based analysis showing that at a large-scale deployment of the Bridge model of social work at Rush University Medical Center statistically significantly reduced all-cause, all-hospital readmissions by 20% at that organization. Another role type in transitional care that is increasingly common to see incorporated in transitional care work in enhanced services deployed by hospitals are community health workers. And in our field work, we worked with Temple University Hospital, who started a community health worker program focused initially on heart failure and other high-risk patients at their hospital. This is a payer non-specific effort. What we found Temple do to some great success was to invite the community health workers to meet with patients during the hospitalization as soon as they were identified as high risk and eligible for the program. So community health workers were deployed to meet with patients during the hospitalization and try to meet a few times before discharge. They found that this connection while in the hospital made it much easier to continue the relationship in the post-hospital setting, again emphasizing the importance of a relationship and trust relationship, familiarity, and so on. Community health workers noticed that patients felt more comfortable telling them about psychosocial and economic problems that might interfere with following through on the care plan, such as being able to unable to afford heat in their home or not really understanding what the doctor said. And it was this trusting relationship outside of a medical clinical context that allowed this more fluid and more transparent communication to be exchanged with the community health worker. As we have engaged with hospitals to understand their enhanced services across the country, we've seen that it's increasingly common to not only see social workers and community health workers involved in delivering transitional care prior to discharge and in the days to weeks following discharge, but really it stands to reason that the most common way we see community health workers and social workers and others incorporated into transitional care is through an interdisciplinary care team. And this example here describes a interdisciplinary transitional care team from a large safety net hospital in California. Their transitional care team was comprised of 8 members, a pharmacist, a COPD nurse specialist, a heart failure nurse specialist, a social worker, 2 community health outreach workers, a program manager, and a data analyst. And by no means are the quote non-clinical staff afterthoughts. This is a truly integrated, interdependent 8-person transitional care team that relied on each member of the team to achieve the outcomes that this team was getting with their high-risk patients. The team identified high-risk patients as those with COPD, heart failure, or HIV, and they actively screened for patients while they were in the hospital, and every query, every time they met a patient, they always screened for housing issues as well as active substance use issues. They described their work not in clinical terms, but rather to actively support patients, to accompany, support, touch base, follow up. This is the collective work of this interdisciplinary transitional care team. Interestingly, they found that their patients responded well to not making individual appointments, but rather to hosting drop-in office hours in an outpatient conference room so that high-risk patients could come and check in with a nurse, review meds with a pharmacist, check in with the community health outreach worker, and otherwise feel connected to this interdisciplinary team. Notably, all of the clinical members on the team were specifically hired for their willingness to do home visits and active outreach and home and community visits meaning in parks, on benches, at bus stops, in the Dunkin' Donuts, et cetera, is part of the outreach work that defines the success of this interdisciplinary transitional care team. So that model bridges us very well into a natural next set of target population patients, which can be described as patients with a personal history of repeated hospitalizations, otherwise known in shorthand as high utilizers of the hospital. To be sure, transitional care work and improving care for high utilizers is part of a continuum and a spectrum. So as we describe the previous models of, quote, transitional care, you'll appreciate that those models are usually based on the key milestones of identifying a patient at high risk of readmission, engaging with them during the hospital encounter, and continuing a supportive relationship to mobilize services, supports, and linkage to service in the 30 days following a hospitalization. The purpose of transitional care would be to address post-hospital needs so as to reduce a 30-day readmission rate. As we move into improving care for high utilizers, those distinctions get a little blurred, most notably because the time horizon of service for high utilizers is probably a little bit longer, in some cases quite a bit longer than 30 days. These are patients that would be defined by their personal repeated use of the hospital setting, and typically teams that are working with frequently hospitalized patients find that these patients do have a balanced mix of clinical, behavioral health, and social complexity, often in intertwined and interrelated ways. So as you think about the high-risk subgroup called high utilizers, you may want to incorporate in your root cause analysis and an understanding of the multiple complexities that lead a patient to be hospitalized frequently within a given time period. What we've found in our field work and emerging as some very practical principles to guide high utilizer programs are the following bullet points that we describe in more detail in the narrative component of the guide. Number one is to identify the patient in real time while they are here on site. That the observation is that sometimes for a variety of social and behavioral reasons, patients are difficult to connect with in the community setting, and so our real opportunity to connect with patients that are high utilizers of the hospital is while they're here in the hospital. We encourage teams to view high utilization of the hospital as a symptom of unmet needs. So the very fact that they have been hospitalized so frequently should become a marker for us that there is a root cause or a set of unmet needs that we have not seen or not adequately addressed yet. We need to prioritize the human relationship-based engagement with patients so that we can create the trusting and effective engagement with people while they're here that will allow high utilizer care teams to continue to serve patients once they leave the hospital. You're going to want to deploy an interdisciplinary team, much like the one from the Safety Net Hospital in California that I just described. Often the interdisciplinary team is a balanced team of program management, data analysts, nursing, advanced practice nursing, pharmacists, social workers, outreach workers, community health workers. A principle that has proven to be very feasible and important is to be proactive in following up post-hospital with these patients. We want all patients to have timely post-hospital follow-up, but in particular, if we are successful in these above principles of identifying a high utilizer in real time, initiating a successful engagement, then by all means, these are the patients who need to be prioritized for early and definitive post-hospital follow-up to continue the relationship and to continue the engagement. You can expect that the team will need to be patient and persistent in their work to assess, address, understand, and support patients in ways that will help to address why they are so frequently hospitalized, and that this is going to take patience and persistence, expecting that a high utilizer may continue a pattern of repeated hospitalizations for a short while until these root causes and until the care-seeking behaviors, patterns, and needs are addressed and met so as to slow that cycle of hospitalization. Often teams tell us that it is indispensable to their work to have access to small type of resources in order to meet patients' short-term needs. These may be cash resources to address economic needs. They may be resources to bridge patients for short-term housing or other or transportation or other types of needs. Flexibility and creativity in resource deployment has proven to be something that many teams tell us has been valuable. And finally, a consistent principle that we see in improving care for high utilizers is to use care plans to improve care across settings and over time. These patients often are connected with a variety of providers. It's not that they lack access necessarily to any providers, but oftentimes we find they are connected with a variety of providers, a variety of agencies across a variety of sectors, and part of the solution for some patients is to get the disparate sectors, providers, actors on the same page, and care plans can serve to do that. So here's an example from a high utilizer program. The high utilizer program manager said, quote, "We do whatever it takes." And that's really a foundational concept that high utilizer programs embrace. So this example is a high utilizer program defined as patients with 4 or more hospitalizations in a 12-month period. They used their data analysis to find that last year's data, there would have been 400 patients who were hospitalized 4 or more times at their hospital in the 12-month period. Collectively, these 400 patients used over 2,200 admissions, and as a group had a readmission rate of 40%. The program was again based on data and quantified analysis. They then they interviewed patients and interviewed providers to develop the interventions for the program. The program was thus designed to prioritize engagement, proactive outreach, the provision of social and behavioral health care, referral to palliative care, in addition to medical and nursing oversight. They set up their team to be comprised of 3 teamlets of a social worker and community health worker pairing, and those 3 teamlets are supported by a nurse care manager, a pharmacist, a medical director, and a data analyst / program manager. This program prioritizes in-hospital engagement and has been successful so far in engaging over 80% of the high utilizers when they present to the hospital. They've also been remarkably successful in prioritizing timely post-hospital follow-up, and currently they are able to successfully have closed-loop definitive follow-up contact with about 65% of the high utilizers within 2 days of discharge. The program is tracking 30-day readmission rates as well as pre-post intervention utilization data, and they're planning on using, and we're working on using an internal historical control group for comparison. So this example of a high utilizer program that's underway based on their internal data analysis, based on quantifying the size of not only how many people, but how many discharges their target population was accounting for, and then used root cause analysis and patient interviews to design a team and the services that that team would deliver in response to understanding the specific needs of that patient population. So moving from high utilizer programs takes us into one of the newest tools that we're seeing emerging in high-risk / high utilizer programs across our fieldwork, which is to use care plans to improve care over time and across settings. Of course, we recognize that the presence of care plans has been a tool in care management for a long time. I think that what we're observing is that care plans and types of care plans and uses of care plans are becoming more common in the lexicon of readmission reduction teams and high utilizer teams, and so it's helpful for these teams that are now considering using and deploying care plans to think about the different types of care plans as well as the information that might be helpful in each type of care plan. So again, this information that we share here in the guide is based on our fieldwork and watching and observing care management, transitional care, and high utilizer care evolve over the past several years. We observed that there might be 3 types of care plans that are germane to high-risk, high-utilizing patients in the spirit and in this domain of reducing readmissions. The first type of care plan might be called a longitudinal or a comprehensive care plan. This is the care plan that has been classically in place through disease management and care management programs for a long time. This would have a multifaceted assessment of clinical, behavioral, functional, economic, social support type of assessments There would probably be a depression screen and a chronic disease management screen, et cetera. And improvement in health-related goals would be measured via serial assessments over time. We, of course, in this work to reduce readmissions, we see a transitional care plan is emerging. The transitional care plan would really be focused on the needs and and addressing needs in the post-hospital time period. That most likely that 30-day time period, during which time the transitional care worker of whichever discipline would be working with the patient to effectively address and link the patient back into post-acute or community-based services so as to avoid a readmission. Finally, we're seeing emerging this care plan, which I'll call the ED care plan. This would be a care plan that would bring to light in very succinct terms, the utilization pattern as well as the clinical, behavioral, and social needs that have become known by an interdisciplinary high utilizer team, but provided to the ED clinician in a summarized fashion so that it is at quick reference and can be readily used in the busy workflow of the emergency department. Oftentimes, an emergency department care plan is distinguished by recommendations to the emergency department clinicians about how to promote safer, higher quality, more standardized, less variable care, especially for patients who are frequently in and out of the emergency department. This is the type of care plan that we'd like to discuss and present to you for your consideration as we see this really emerging in our field work through updating this version 2 of the guide. So the ED care plan, as an emerging tool in the field, we identified that the purpose of an ED care plan would be to improve the management of the high-risk, usually high-utilizing patient the next time they come to the emergency room. So the audience are ED clinical staff, and the content for an ED care plan would be to provide an abbreviated executive summary of prior utilization, how many emergency room visits in the past year, how many hospitalizations in the past year, as well as a summary of the relevant testing. Have there been repeated CAT scans, stress tests, other types of clinical testing and imaging that would be germane for the ED clinician to know. We have discovered recently that the concept of identifying the driver of hospital utilization. You heard me say a few minutes ago that high utilization is a symptom of unmet needs. What is the driver? What is the reason why the patient repeatedly comes to the hospital? That is not the chief complaint. It is never the admitting diagnosis. It is the story behind the story, and that takes some work to diagnose and understand. The ED care plan would include recommendations for the ED clinician's consideration, such as avoiding certain controlled substances or maybe exhibiting parsimony with decisions to engage in repeat testing. It would invite the ED clinician to contact the dedicated transitional care or high utilizer care team. And importantly, it would identify a point of contact, not just that the patient is enrolled in a program, but who to call, what the email is, what the phone number is, a point of contact, again, to make it easy and quick for the treating clinician in the emergency department to reach out to your team to say, I've got a person with one of your care plans here, here's what they look like, let's talk about next steps. So in the process of learning about and observing the use of ED care plans, we have provided in Tool 13 an ED care plan template, which is an amalgamation of a variety of types of examples of ED care plans we've seen from a variety of different hospitals across the country. This, you'll note, at Quick Scan is set up as in an SBAR format. Really, there are a few design principles here to be cognizant of. This is not a comprehensive electronic medical record. It is meant to be a quick, at-a-glance summary of salient information. Think of it as the executive summary for the emergency department clinician. There's almost universal agreement that the emergency department care plan should be short, that shorter is better, and for heaven's sakes, it should not be more than 1 page. And these are points of feedback that we've received from the field. And so it's with these points of feedback and observations of what's out there that we provide this version of an ED care plan template, as well as a few examples in Tool 13 of actual ED care plan templates that we have obtained during our field work over the past several years. And so you can see this is an example of an ED care plan template, and we have learned from teams in the field that having examples of the amount and type of detail is really helpful to paint a picture in order to move forward and to start testing and using and developing ED care plan templates for yourself. I've mentioned a few of these design principles of ED care plans. Our lessons from the field include that these should be short, that the information should be focused on the intended audience. And so if the intended audience are ED clinicians, using short-term medicalized abbreviations is perfectly fine, and develop the clinical snapshot and the recommended interventions with the end user in mind. What do you want the person reading this in the emergency room to do with this information? Always remember to summarize the utilization part of the high utilizer. Yes, there are 22 meds and 14 problems on the problem list, but really what we're trying to do is create that profile and that summary information of the numerous and repeated presentations over time. And so make sure that you have a part of the care plan that summarizes the utilization profile. And then finally, a tip from the field is delegate the synthesis of the information, collaborate on developing the plan. So what we mean by that is that it does take time to develop care plans and to extract the information from the chart for a high utilizer that has been here dozens of times over the past year. You can delegate the collection and synthesis of that information to a member of your high-risk care team, and then bring the information to case conferencing so that the full interdisciplinary team and anyone else you might invite to collaborate with you can develop the care plan and next steps together. That seems to be an efficient way to get the job done. Finally, in our last segment of this last webinar, we'd like to spend a moment talking about engaging the emergency department in your general work to reduce readmissions. And so this, again, leads us from the use and development of ED care plans into other strategies and other ways in which the emergency department is a really important place in which to initiate and strengthen your readmission reduction work. A quote from one of our field teams said, quote, "In previous times, the path would have been to simply admit the patient and we'll sort it out 5 days later. We're becoming more accustomed to having resources in the emergency room to help us discharge patients from the emergency department. That's a culture change." So we have noticed that there are some very specific and almost universal elements that readmission reduction teams should be able to incorporate into their work by starting readmission reduction efforts at the front door of the hospital, not just focusing on the transition out of the hospital. So number one is many hospitals have the ability to create a 30-day return flag on the ED tracker board. You may have one in place. The big key here is if you have a 30-day readmission flag on your ED tracker board, be sure to communicate what you want the clinicians to do when they see that flag. Number 2 is to use the 30-day return flag to notify any sort of transitional or high-risk care team that you have. The real-time notification of a dedicated team allows that team to respond to the patient while they're still in the emergency room and collaborate with the ED providers on identifying opportunities for a safe discharge instead of a readmission. Number 3 is use care plans, as we just discussed, and use the care teams to be involved in decisions to admit from the emergency department. So what we mean by that is that the care teams and, by extension, the care plans can communicate some important things about high-risk patients, such as baseline clinical status, recurrent utilization, drivers of utilization, and next steps when predictably the patient returns to the emergency room. This is the opportunity for the care teams to say, we know this patient, we've created a relationship and a longitudinal knowledge of this patient, and we know that this does not appear to be a significant change in clinical status for this individual. And that, of course, would allow a new conversation with the emergency department providers about alternatives to readmission. Number 4 is consider developing treat and return pathways. What we mean by this, we'll give an example in just a moment, is oftentimes when patients come to the emergency department from certain referral centers, such as skilled nursing facilities or rehabs, there is a sense that the patient needs to stay and be admitted and be cared for in the hospital because the facility is the one that sent the patient here. And what many emergency rooms and readmission reduction teams are working on now is better communication and processes in order to treat, evaluate, and whenever safe and appropriate, return the patient to the skilled nursing environment instead of admit them to the hospital. And number 5, through field work and focus groups, we have identified that hospitalists have encouraged readmission reduction teams to include them in the decision to admit in collaboration with their emergency department colleagues. This would create a culture of collaboration in the decision to admit. And again, just as interdisciplinary transitional care teams benefit from different perspectives and different skill sets, so too are we proposing that the decision to admit a patient would benefit from closer collaboration and greater collaboration between the emergency room and hospital medicine. So we'll close out this section with 2 examples of engaging the emergency department in efforts to reduce readmissions. The first example is the treat and release, treat and return for skilled nursing facility patients that are sent to the emergency department. And what we have here is an example of a Massachusetts community hospital that examined their readmission rates and their admission rates among patients sent to them from skilled nursing facilities, and found that essentially all patients that were sent to the emergency room from a skilled nursing facility ended up being admitted. They then engaged in a process of asking 5 whys, why do we admit such a high percentage of patients from the skilled nursing environment, and went through a series of discovery discussions around why these high admission and readmission rates might exist. They then moved into trying to mitigate some of those preconceived notions by expanding their understanding of what the skilled nursing facilities could do in their region. Which ones could administer breathing treatments, which ones could administer IV therapy, which ones could have same-day urgent lab testing, et cetera. And by doing this, the ED chief that was the champion of this effort challenged his team to just treat and return more patients that come to us from the skilled nursing environment, return more patients this week than we did last week. And slowly over time, actually over just a series of weeks and months, they steadily increased the number of patients that they were able to successfully treat, evaluate, treat, and return from emergency department to skilled nursing facility, thereby avoiding not only avoidable admissions, but avoidable readmissions as well. Another example comes from a very successful high-risk, high-cost demonstration project. And this demonstration program, I think, summarizes the key intervention with the quote you see here on the screen, quote, "Our patients look bad on their best day," end quote. And for those clinicians who are listening, you'll recognize what this means. It really reflects the importance of longitudinal clinical knowledge. What is our patient's baseline? And this care management program was charged to reduce cost and utilization for the most expensive patients at this hospital. And among the strategies they used was a flag in the emergency department, which automatically notified the high-risk care management team whenever one of their high-risk, high-cost patients registered in the emergency department. The expectation was that someone from the care management team would respond to the patient in the emergency department and collaborate with the emergency department staff to identify whether a discharge rather than a readmission is inappropriate. In reflecting on their success factors, the program manager did cite the longitudinal clinical knowledge of a patient's baseline, reflecting the fact that some patients always get winded when they walk from the car to the front door of the office building, or some patients have chronic anxiety disorder and have a consistent and predictable set of somatic complaints to go along with their anxiety disorder, and so on. And really, it's that baseline that helped the care management team as well as the emergency department staff better determine what really represented an acute change in clinical status versus what represented a either zero or modest change in clinical baseline. So in summary, this section on deploying enhanced services for high-risk patients encourages hospitals to deploy those enhanced services for patients who are at high risk of readmission, for whom the best transition out of the hospital and the best reception back into the next setting of care will not suffice. We encourage you to match the enhanced services to the needs of your high-risk patient population and specifically consider different services for different target populations when necessary. We encourage you to not over-medicalize the services. Excellent medication reconciliation and clinical management and follow-up is always needed, but that's often not the full picture of what's needed. We encourage teams to develop care plans, particularly for patients who are frequently hospitalized, and particularly to help the emergency room team know and understand these frequently hospitalized patients and their drivers of utilization better and quicker so that they can help to be part of the solution to improving and increasing the quality of their care, reducing variation, and helping to better collaborate with you and your high-risk care team. Finally, we encourage you to engage the emergency department more broadly in your effort to reduce readmissions if you haven't done so already. In particular, use flags and notifications, have your care teams or your hospitalists collaborate with your ED clinical staff on the decision to admit, and use care plans to promote safe and effective care for high-risk and high-utilizing patients. So thank you so much for attending webinar 6 of our 6-part series, and thank you for your commitment to reducing readmissions. On behalf of my co-investigators, Dr. Angel Burgoyne and Dr. Jim Maxwell, I thank you for joining us, and have a great rest of your day.